special call meeting, February 1st, 2024. Title is Thomas Hospital Expansion. We want to thank everybody for coming out today. Today we will have the city council is here. I think the only council person that's not here today is Councilman Boone. We have our Board of Adjustments here, and we have our Planning Committee here. And also we have a representation, Mr. Nix, Mr. Orman, from Thomas Hospital. So we welcome everybody to our meeting. Sticking to the agenda, getting business started. We'll call the meeting to order, and we'll have a discussion of the potential of Thomas Hospital expansion, and we'll start with Hunter Simmons.
Thank you, Councilman. Bear with us. We've got a little bit of a change in the way we organize things. So did we get started live, John? Excellent. Do we have our architect with us online? Excellent. So the architect that
Excuse me, Hunter. Let me say something real quick to each of you, so you know that those mics are live. So any sidebar conversations, guys, they will be picked up. Just want to give everybody a heads up on that. Okay. So just be familiar with that. Okay. Thank you.
Thank you.
Yes.
We do have representatives from Thomas here, and their architect is joining us online. I don't think we can share his screen if he needs to, but here, in case there are any questions or clarifications, or more specifically, if there's any guidance in the future. I'm going to kind of introduce a little bit of this, but I really want this to be discussions from our board, planning commission. I think why we're here is to try to give Thomas as much valuable feedback on the plans you're going to see. There will likely be future meetings on a site plan review and potentially even variance cases that come to the Board of Adjustment. I want everyone to understand here, we're here as in an informal capacity to review plans, very similar to informal review for the Planning Commission. You're not obligating yourself to vote one way or another. If we see a site plan review or a variance case, we are here because Thomas is certainly, as the comp plan says, they're one of our largest employers, economic engines in the city, and certainly a valuable asset in our health care and quality of life. So we're here to help in that capacity. And to kind of lead into some of this, just a little history. Thomas isn't familiar with site plan reviews. These have been going back since in 2000, 2007, 2016, 2018. Most of the additions went through these similar processes. 16 and 18 were only the parking lot expansions, no buildings. In 2011, there was a medical overlay district that the city adopted. That imposed some different regulations. So it is the first building expansion we've seen at Thomas since that medical overlay district. That's going to come up in a minute, where the processes are a little different, and I want everybody to be aware of that and how we navigate through that. There are right now, as you'll see in the plans, at minimum a couple of variances that would be needing to a setback. I'll get into the details on that, and to a building height. The building height, once you get 1 foot over the building height, the variance is kind of subjective. So is 32 feet too high, or is 70 feet too high? That's where I think the feedback here is just me and my staff giving feedback is maybe not sufficient. So with that said, the aerial on the screen, and we're a little different seating so that can everybody see this. The aerial on the screen, the blue bar, this is just aerial of the regional area. You can see the campus hospital, or the hospital campus. The blue area is the location of the proposed addition. I'm going to, in essence, just zoom in here. So you can see that this is approximate, my drawings, and not as accurate as the architects, but this is approximate location. And we had some one-on-one conversations about this location, and it is in the medical overlay district. I've highlighted a couple of things there. You each have a copy of the medical overlay district. That's straight as it comes out of our zoning ordinance. The intent here is to create a district. Again, this was in 2011 to support the medical industry uses and the supporting uses. And that goes all the way down to Greeno Lane. So the image on the screen, the blue line is that medical overlay district. While I'm here, I also want to note the light pink color. I'm going to come back to this, but the property that Thomas Hospital sits on is zone B2. That's going to have a nuance here in a second that I want to be aware of. In those one-on-one conversations and presentations Thomas presented, this is kind of the first draft of an idea, and it included a parking deck with 2 floors of hospital beds. I think everyone is needed, and I hope it goes without saying that we are here to support those increases. Everybody sees the need at the hospital for the hospital beds. So that was not in question of our support for that. There was a couple of images presented, and in this image you can see a kind of an offset. There below was parking with 2 floors of hospital around. So within this addition, they proposed to accommodate the parking necessary for the bedrooms. I believe there might have even been some extras, but we didn't get into the exact numbers of this. There's been a lot of, they've really reacted to our concerns and we're moving fast. So this would be the elevation on Morphy Avenue. We had additional meeting and kind of some conversation about that, and we've received revised plans. And the elevation you see on the screen, so the top one is if you were able to step back on Morphy Avenue and look back at the hospital. On the left-hand side, you can see the portage shaft to the emergency room and the north tower. And then on the right side, you see the proposed addition. It is currently proposed as the first floor is parking. The second floor would be 27 beds. 25 new hospital beds that has to go through some state licensing. That's also going to be imported in the timeline here. The top 2 floors would be a shell for future expansion of the hospital beds. And then on the bottom elevation, you see that west elevation, that would appear as from Ingleside Avenue. So you can see kind of the entrance to the parking there. We did receive a landscape plan, and critical to some of our internal conversations was Morphy Avenue, which has been designed since the early 80s, I think even the 70s, about the landscape as it appears. It's one of the entrances. It's earmarked as a critical road and has certain requirements. So the first proposal didn't leave a whole lot of room for the landscaping when you consider we also had some other infrastructure improvements in that area, such as overhead power line, transmission lines. I always get those confused. Transmission lines coming in that are the big, tall, hurt you kind of lines. So there was a lot of conflicts in a small space. This plan revised that, got the building back inside the 20 feet. And the proposed layout is here. It's overlaying the existing kind of survey. Now, these are revised elevations of the architecture. It does not include the landscape that you see on the plans, so the overstory trees every 30 feet on Morphy. It does not include that. Again, this is on the Morphy side, the broad side, so it does not include the new landscape architecture shown on the plans. As these come to you as board members, whether that's Planning Commission, Board of Adjustment, City Council, those things will be fleshed out. We will have better plans that will get all this. Again, this has been moving pretty fast. This is also looking west on Morphy, back toward town. And then north, you can see that emergency room exit right there on the top side of that picture. This is mine. It's not accurate, but just a model. We wanted to kind of see what it looked like with the actual surrounding area. So we took a drone shot a couple of days ago and just roughly modeled this in. So take this with a grain of salt. It's not accurate to the foot, but gives you kind of a massing idea of what that would look like there on The corner, this is looking east along Morphy, so you can see the hospital, Greeno Road in the background. And this would be looking back toward the bay to the west, and how it would sit there on the corner. Those are the images. Just to touch base a little bit now on, I think, why we're here. And I'll use the surgical center and also the tower expansion. Now, those were in 2000 and 2007. Those came through some of these same processes. They didn't have to go to Board of Adjustment because a variance wasn't needed. B2, if you remember the zoning of B2, B2 zoning doesn't require setbacks on Ingleside. So the surgical center doesn't have that. It's the medical overlay district. When it was adopted, it has an overlay dimensional requirement that says everything should follow B4, which implements a 20-foot setback. Yes, sir. So some of those things in the past we're dealing with now for the first time, and I'll be honest, I wasn't here during the medical overlay district, and any of you that are, I welcome the feedback. I'm not sure if this was really contemplated in that when that district was proposed. It seemed like it's more written toward the growth on the south side of the medical overlay district to support that neighborhood. I'm not sure if that was an intended consequence. However, and as the height also was reduced, it was 35 feet high, and it's now, based on the medical overlay district, 30 feet. Now, we're looking at a building that is approximately 68 feet tall right now. So the medical overlay nor the base zoning we don't have, I don't think, anything in the city that would have that. We also don't have a hospital that the core was built years and years ago that has buildings that tall. So they are proposing to match the same height. So with that said, I'll offer, Thomas, if y'all have anything to add before we kind of get into discussions, if you would like.
Yeah.
Sure.
Yeah. Yeah. Yeah.
Yeah, you can come up here. We got a mic here, I think. Sorry, it's a little cramped over here. That's normal.
Orman, if you could kind of just give the audience and the congregation an opportunity to think about what exactly Thomas is looking for as far as direction or things that you want from us, as far as this particular body is concerned.
Okay, Councilman Warren, I'll do that. And this is new for me. As we said, we have not gone through I've not gone through this process, and what we've done has been internal over the last 5 years in the hospital. I do want to thank the mayor and council and the board for taking time. Everybody's very busy. Thank y'all for your time today and taking time out. But through COVID, we built out all available space within the hospital. We've added 14 medical surgical beds. We've added 13 additional colony rehabilitation beds. They give us 25 beds there. We just added 5 additional ICU beds internally, and we're just capped out internally from where we can add. So that's why we've come to this conclusion. We've got these beds. We petitioned the state at the end of 22 for additional beds. There's a provision with state health planning that if we reach a certain capacity over a 2-month period, we can request a bed addition. That's kind of how it works with the CON board and state health planning. So we hit those marks, and so we requested this addition. We can request 10% of our current licensed beds or 30 beds, whichever is greater. We requested 30 beds. We received those in March. We've been planning, really working internally to plan where's the best location from a logistics standpoint, a patient care standpoint, for this new tower. And that's kind of what we've come back to here and come back in discussions with the city. And so really, I guess we're asking for you all's help in helping us work through this process, give us some direction on what we can do within the city's framework so we can get the project started. The beds are there's definitely a need for us to keep pace in our community, in our county, to care for patients. If you know anybody that's been in the hospital lately, it's extremely full. Patients are in the ER waiting for beds. It's not the greatest patient experience. They're getting cared for, but it's not the greatest patient experience, and we can do better. We want to do better, and we need these beds to keep pace with our community and then to grow additional beds and grow the Sheldon space as time permits and as we need to do that. Thomas is really a regional draw for patients. We're fourth in the state in open heart volume. So if you think about all the hospitals in the state, we're fourth in that volume. So we have a lot of patients coming regionally to be cared for at Thomas Hospital. A lot of great doctors, great staff, and so the addition is very, very much needed. Any questions I can take from anybody, or?
Anybody from the Board of Adjustments or the Planning Commission want to speak on this particular matter? I know we've come together on several occasions. Lee, I know you were in one of those meetings, and we can kind of speak on the things that we kind of alluded to in those meetings and kind of put it in a public lighting at this point.
Yeah, as far as on planning and zoning, I've been on that board for over 30 years, and if this was just a regular office building, wouldn't even think twice about it, or an apartment complex, allowing something like this. But one thing in all of the different comprehensive plans that we've had, when we look at what, is really important to Fairhope, the hospital is one of the things, if not the thing, that so many of the retirees and people that move here think about. Wearing my single tax hat, we funded years ago $1,075,000 for the birthing center, to help the hospital build the birthing center. And it was about 18 months between the pledge and the actual funding of that money. And we did a calculation afterwards that every single one of our directors and officers, of the 16 of us, had either been in the hospital ourselves or had a family member in the hospital. Showing you how important the hospital is. And I don't have to tell anybody here that. Everybody knows that. And as we always say on the Planning and Zoning Commission, whatever we do for one, we have to do for the other. Well, this is the only hospital that we have. And as it was originally, Corey, as we looked at it originally, I wouldn't have supported it like that. It was just a little bit too much and too close, and the ingress, egress, some of those issues. But as far as the redraw with the, additional feet, and having the entrance and the exit off of the, not coming off of Morphe, and that additional little bit of space between Morphe Avenue and the building. Again, if it was an office building, I wouldn't support it. As a hospital, I absolutely would. The one thing that I would throw in, just, my personal taste, is I think the trees that we look at between Morphe and the hospital ought to be probably different, rather than just requiring certain types and calipers when they're planted. I think we probably ought to, look at the types of trees planted there, and get some trees, like magnolias, that have some, will block, the view a little bit, and also some trees with some height to them, to try to lessen the height. And I talked to Paul Fontenot about this. It wasn't, he's a landscape architect and the chairman of our tree committee, and he looked over it and he liked the changes that they made. He was at one of the meetings with us a few weeks ago, and he really liked and approved the changes they made. And the one proviso he said is that the landscaping needs to be, you don't want Bradford pears and crepe myrtles, throughout. You want some trees with some height, and some trees that are maybe some natives that'll be there for years, not trees that'll grow up 10-15 years and then be gone. Something that'll take the scale of the building down a little bit, since you've got such a large building close to the road. The more trees that you have and the higher they are, the more that building will fit into that residential surrounding on the other side of the road.
Very good. One of the things that we are up against as we all do our due diligence on this particular project, first of all, I agree, everybody wants to have a win-win here where we make this thing happen. So that's why we brought all the minds and everybody to the table to try to see if we can help Thomas, which is a partner of ours, their family to us, and we want this project to happen. We just want to make sure that we cross our T's and dot our I's. The variances that we have to incur during this process, we have to think about those as far as setting precedents in other aspects. Once you're saying do it for one, you have to do for other. Those things we do have to think about. So instead of just saying no, while we're coming here today, as I see it, is us kind of talk about how can we do those things? What does that look like as we move forward if we decide to press upon those variances? And you have to think legalities as well in all type of fashions. These are the things that I want the body to think about and to kind of speak up about today as we come together to try to make this project happen.
Corey,
Yes, sir.
if I may.
Yes, sir.
Hunter, walk us through this, sort of speaking of the variances that Corey was just talking about. Let's say this was formalized in the next 2 weeks and brought to the city for approval. What would have to happen? I know we've got 3 different groups here today. Walk us through the steps of what would need to occur, what variances or adjustments would need to be made through each step before it got up here to us.
Sure. So, and I do have just some cheat sheets that I'll kind of pass around, because it's kind of sometimes a little hard to think about all the things we review. Some site plans, subdivisions, everything, what is the criteria? So this does have the criteria. There's one for City Council, Planning Commission, and one for Board of Adjustment. The variance would be the first domino to fall in a review. Right now, with the currently proposed plan, we know that would be a height and a setback. There could be some other minor, depending on some site guidelines, we're not there yet.
So Board of Adjustments, first step, get the variance.
Board of Adjustments get the variance for
For
the
height and setback.
setbacks.
If Board of Adjustment says thumbs up, we'll give it to you.
Yes.
Then they take it to,
And that then will go, the only thing triggered here is a site plan review. Anything over 10,000, roughly 10,000 square feet for addition goes through a mandatory site plan review. So that will go to the Board of Adjustment, the Planning Commission. That is not a public hearing like a subdivision or a rezoning case. So it is a little bit more expedient. For our advertising requirements at the state level, that once it goes through Planning Commission, theoretically could be back to council within 3 weeks. I've just looked at the last 2 that went through, and it was roughly 3 to 5 months from Planning Commission to City Council. Planning Commission gave some feedback, and by the time the revisions were done, and it's in council, but I think that was more on their side, some of the design engineers working through some of the details. So best case scenario, if we've got application in 2 weeks, we're looking at a 3-month process. Again, adjusting to some of the comments through that process can prolong that.
so I'm just trying to think through it on, from a rules and a procedure standpoint, other than the variance for height and setback, are there any other ordinances or rules that we have that the plan as written would violate?
So there is a couple of things that, as your planning director, would advise. One is the variance, and I think Councilman Martin mentioned a precedent in creating a variance for something. I would recommend that if we're looking at a variance for height specifically, we amend the medical overlay district to allow us to be able to view Thomas Hospital of itself as very unique, with buildings that have been there before these regulations, to be able to do that. Now, that would be a council decision for a zoning text amendment that could take longer than this process. But in previous cities, and this one, of course, we'll have to confer with legal, we have moved a project along with the goal of wrapping that up in a revision to the zoning ordinance. I think that will take care of the precedent. There are other things that I just don't know right now. There's a lot of other people. One of those that I'm kind of concerned about, but till we get further down the road, we've got some site clearance guidelines at intersections, for example. You've got to be able to pull up to a stop sign and be able to see left and right. This building is currently sitting, does that get in that? That's more of a right-of-way ordinance, Chapter 19 of your city codes, and I'm going to lean on other people to do that. And that's part of the process when we get the application. So There's no variance process for that. That's just amending the building.
Yeah, I think Corey's right, as far as the considering the precedent of, a variance. But I do agree with Lee that when you're, treat one like you treat all, a hospital is unique. I mean, obviously, we have a special overlay district just for that. And so I think you can make certain changes in the ordinance while taking into consideration this specific project to sort of eliminate that or eliminate any potential future conflicts with somebody else in another area wanting a similar adjustment, because it's not an apples to apples if you're not looking at a hospital, I would say.
Well,
That's correct.
yeah, I want to do one thing, and I think we're going to have a win-win on this, but I just want to kind of challenge and ask Orman and Mr. Nix, as far as say, let's be devil's advocate right now, and let's say we run into a whole bunch of legal jargon, blah, 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 with all this variance and stuff. I think we can make an amendment, but say hypothetically we run into something that we just cannot hurdle, go under, go around. Are there any other, so when I look at this, can we not take this block, have y'all thought about taking this block and sitting it next to the medical offices, next to that dead space? And then, I practiced anesthesia for many years. I've been to UCLA, UAB, Shands. Like, I know it is not something that you would want to do as far as making your laborers work or travel, or even your patients have to walk or travel to a certain spot, but you can create tunnels, pathways where patients can get transported and back. Is that something as a contingency that we could have, or thought process, and would that fit the master plan going forward with the thoughts of Thomas Hospital?
I know we've got Neil on, the architect. I'm not an architect.
Yeah, I just didn't know if you know if it's
I am in operations, and back to your point,
Yeah.
we looked at dropping blocks in all over the front of the campus, side of the campus, and we wanted something from a patient care standpoint that was contiguous to where the patient care takes place. So whether it's ER, the procedural areas, imaging, where the patients can be centrally located and not, once again, shipped across campus. I hear you on UCLA, and I've been to those places too. But if we could do this, this was the primary location. I mean, obviously, if you got to take a step back, we got to take a step back, but that would not be ideal when we talk about operations.
Okay.
Well, can you talk about the back of the house stuff that you talked about with us? I mean, this is kind of where all your continuum of care is, where everything is for the connectivity.
Yeah, and once again, it's contiguous to the cath lab, surgery, imaging, radiology, x-ray, those kind of things, ER, where those patients can be seen if they need to come be seen again, or they're coming from surgery. All that stuff is kind of centrally located for the patients and families to keep them within that particular area. And that was kind of what kept pushing us back to this point, and not putting it out in front of the breast center, in front of the hospital. We looked at some, in all transparency, we looked at the front of the hospital as kind of growing out there. But you've got to keep natural light for the current patients. If you start blocking windows, that creates issues for the current patients in their rooms, and blocking that natural light. Also, the front of the hospital is a great place for us to continue to grow out as we expand support services, registration, kitchen, dining, outpatient diagnostics, were easier for patients to come in on the front side. So that's another reason we didn't go to the front.
Yes.
And Dennis can jump in, or Neil, but that's kind of why we kept getting back to this, because it's very centrally located to those procedural areas and things such as that. It's great. I mean, it's a great question.
Yes.
And I appreciate the comments.
Mr. Chairman, may I?
Yes, sir.
Okay. I like the reason you explained, that you want to make the expansion at that location. That makes a lot of sense to me, and I think that everybody in this room would say that if they have to go to the hospital, they'd like to go to the local hospital, not to Malbus or Mobile or Foley or anywhere else. I know if I'm going into the hospital, and unfortunately I've been in that hospital several times, it's nice to be 2 miles from home. So I don't know that there's anybody in here that would oppose a hospital expansion, and Mr. Turner, you touched on that, and for all the reasons that you stated as well. So I support that. Hunter, you mentioned the process of going through the Board of Adjustments and the variances, and I hate to oversimplify this, but I think it's very simple. I think you change the medical overlay district, you change the zoning of what's allowed, and you got to put some stipulation. You can't just blanket change it because people will take advantage of that, and I'll get to some details on that. But I think that, to me, that's the quicker path. I'm not a big fan of variances. I'm just not. I like, I would rather it be by right. You fit within the rules and regulations, and there's no, giving somebody an exception to it. I just, you touched on that as well, Councilman Robinson, and as well as you, Council President. That doesn't sit well with me. Doing it by right, putting it in the medical overlay district. Let me say this: I'd rather them go up than out. And I think, I don't want them to gobble up a lot more land in the city. They got a lot of property there, and I much rather support going up. So what I would suggest is, we could have something written very soon. We'd have to advertise it. We could introduce it. It could be, in council, I'm talking to you, it could be adopted at the next meeting. I think it would be very quick, but it would look something like this, with the exception of the setbacks, Hunter. I'm a little unsure of the setback going to the B4 and the 20-foot and what we could do about that. So that needs to be ironed out. But as far as height goes, I would say that a building in the medical overlay district with, I'm going to throw a number out, greater than 200 beds. And the reason you better put a stipulation on that, because if you say you allow this height in the medical overlay district, you're going to get condominiums there. Whatever we say the height is going to be on the other corner, I promise you. And they're going to say we can do it by right, and there's nothing we can do. So I would tie it to the number of beds. If that number is 175 or 200 or 250.
It'll be up 200 with the.
My number I wrote down, greater than or equal to 200. And then you would be allowed this height. And then in the future, a future council may say if it's over 300 beds, it has to be a certain height. I mean, I don't think Fairhope's going to stop growing, but it does prevent the creep and moving out into residential areas that may be near their other areas. That's what I think. Like I said, I think that's simplifying it, but I truly think if we want this to happen, that's the path of least resistance and the simplest thing to do.
Corey, could I say something?
Yes, sir.
I didn't agree with Jack until he brought it back around, because my concern of that idea of bringing it in the overlay district was exactly what you were saying. Somebody decides they want to bring their medical office in there 60 feet or what have you, and put in the beds. I think that's a great idea, to put the beds in, and then you're basically tying it to this one, and that makes a lot of sense.
Yeah.
My question would be, and I'm never really comfortable on variances, however they're allowed for a reason, and this is maybe a reason, but, and I don't know if this is more of an Anil or a Hunter or a Marcus question, but when it talks about unnecessary hardship, I had a friend who's been, fighting a wound for a while, and he got to the emergency room at 9 o'clock, was finished in the emergency room at 11, but they admitted him, and it was close to midnight before he got to his room. And I don't know if that would be considered a hardship, something that happens to a patient, not being able to get a room for a while, if that'd be considered a hardship. And when it says such conditions are peculiar to the piece of property involved, I mean, it's a hospital, which kind of makes it, a peculiar piece of
Your
property.
mother-in-law needs a room on the house
Yeah.
so you can take care of her. That's a hardship too.
Wait, I want to ask you, your friend got to the ER at 9 o'clock and got to bed by midnight?
That's pretty
Sounds
good.
like it's
That's pretty good, because usually they have to sleep in the ER and get a room tomorrow.
I see, I didn't
Yeah,
know
all
that.
right, yeah, so yeah.
Hey, I'm not just talking, I'm
that-
talking any ER
yeah.
that you've ever
Yeah.
been to in your life. 3
But-
hours is
Yeah.
quick.
So, but yeah, Lee, I hear you. I'm a medical guy, so 100% for this. We just want to make sure that we bring all the smart people together so we can get this right. So please think about things and be devil's advocate as we go through this. One of the things that I think about is a residency program. You guys have a residency program, correct? So we'll definitely have to put something in there that somebody that's really ambitious cannot come in and say, I'm gonna build me a 7-tower residency room for residents, and I'm not against people having development, but we have to make sure that we protect the height, and things of that nature.
Beds need to be clearly defined. I mean, they can't
Yeah.
just say bed.
Well,
It needs to be very detailed description. I know somebody
where
said
residents
keep it
are
simple, keep it
connected,
complex.
where residents are connected to the beds in the hospital, so that seems like a portal of entry, is what I'm saying. So we need to make sure we define that as I think this through, as far as height is concerned. And But yeah, so so far, that's the only thing that I can think of that we could get in trouble with unintended consequences. So, yes, ma'am, Ms. Bryant.
Just to chime in, I really like where we're going with the guardrails, not having a variance, but changing the ordinance. And I appreciated, Paul Thornton's comments that you brought up. If we build in that additional height is required, then having corresponding increase in height of the required trees and the caliper seems like a good proportional response and better for the people in the beds too. And I wanted to thank, I really appreciate seeing the parking tucked under the building. I think that's a great response, especially in this area. And this may just be a can of worms that we need to not open, but looking at the medical district overlay, if we are amending it and looking at where growth is happening, it seems like it doesn't exactly correspond, like it doesn't cross the street on Ingleside where there are medical facilities, and it bleeds out to the south in areas that haven't really. So that may be for a later date, but I just thought if we are adjusting it, maybe take a look at the boundary and see if it still makes sense at this time.
Well, like
And
you
the mayor
said,
brought
though,
that up.
our ordinances are all living documents, and they can always be amended, so.
But we hear you. We're duly noted, for sure. This is what I'm asking for people, right while we're here, to kind of think about these things as we go forward. But
Mr.
Hey,
Chairman,
Councilman.
can I ask? I'm probably gonna.
You first.
I was gonna ask you about the setback. Is there a solution to the setback question?
Yes. So,
In other words, I don't want a variance on that either, if it can be helped.
I think it can. I need to think through some of the details, so don't commit to the specifics I'm saying here. But if you recall, they are the only properties on B2. It was not until the medical overlay came along that implemented the setback for them. Along Ingleside, there is no setback. All the buildings are built to the property line on Ingleside.
we don't want that.
So
But we
this
want
is-
safety.
we don't want
You, to your point of safety earlier.
Yeah, we don't want that.
Right. There is, I
Can't
mean,
do that.
that's another chapter that we need to make sure site clearance is there. But every addition that's been done has been able to build to that property line on Ingleside. I kind of think this was an unintended consequence of the medical overlay district, because every other property from there south to Greeno Lane, I don't think there's any other B2s. Most of that's M1, light industrial, some residential, some other properties, but.
What's the purpose of it being, I mean, what's the purpose in the medical overlay of it being B4 restriction if it's B2?
I wasn't here, but I'm going to speculate a little bit and know that. And Lee, you might remember some of the conversations on the detail. Looking at it, I would think you're kind of growing in a residential area. Some are still going to be residential. B4 had some setbacks. This isn't downtown where we're saying build to every property line. The zoning didn't match for that, where B2 is a little bit more intense in your business unit. It was to match the uses of more professional office, and then medical supporting documents. But that's some speculation that I think Lee might be.
The goal that we were trying to do, that was around the time that Bones and Babies and all of those offices were trying to come in, and a lot of them were threatening to go to Daphne and Spanish Fort and different places if we didn't, allow them to have places to go. So we were trying to hit a compromise between keeping as much of the medical infrastructure in the 36532 as we could without being too imposing on the people who live around there. And your medical offices are B4 anyway. So we were trying to cap it at B4 so you wouldn't get restaurants and other types of retail businesses that might, be more obtrusive and have, less setbacks for the neighbors around there.
And Mike did remind me, one of the pluses, it actually allows to come a little closer to the road. So instead of 35 feet, if you're a R2 property, you were able to go to 20 feet, but also stay away in case there are residences in the back behind on the adjacent properties. So to answer the question, I think that the same boundaries we put on Thomas Hospital for height can easily apply to the setbacks. we could even set back, we can be more specific, because it's really looking at one campus and say, here are the setbacks. On the Ingleside, it's X, on Morphe, it's Y, on Greeno, it's, that's very clear.
Put it in ordinance.
Yeah.
So, yeah,
Okay.
very good.
Now,
I,
there is one, and I brought up those site plan reviews for a reason, because everything is always coming, and it's not to get in the weeds tonight on
Yeah.
parking. But I think this is appropriate. It's a dynamic that we're trying to solve and debate on downtown. It's everybody's got some conversations there. The previous two site plan reviews looked at the building additions in the rooms and kind of said, okay, now there's going to be some parking solutions. So as follow-up to that, I think that in 2016, there was a parking lot addition. As we resolved some of those, okay, where can we get parking in? 2018 came along and another parking area was done. So if we are strict zoning ordinance, there's parking requirement with every square foot you add. I think, again, the Thomas Hospital is a little unique. I don't think there's an intention to not have parking for patients. That's a customer care. That's, I think, a high goal for them as well. So I think that would be something we could also look at in the medical overlay district. It might take a little bit more time to figure out those solutions than we have the need for beds right now.
Yeah, we'll stick with one piece of the elephant at a time. At this point, I think I'm happy. I mean, I think Orman, Mr. Nix, Steve. I think it is everything. Did all your questions get answered as far as where we are right now? Yes, sir. Please, and I want you.
Thank you. For those that do not know, I'm Mark Nix. I'm President and CEO of the health system. And I also, like Orm, I want to reiterate, thank you all for taking the time and looking at this. If you look back at this campus, it's roughly the original piece of property. The first building is like 63, 64 years ago. So even the residential areas that are somewhat around it now weren't there. And we've got some renderings and some photos. It's just a big, wide open field. And if we had it to do over again, we would, we'd go somewhere west and try to build and get out of the way. But it's just financially impossible to do that and replicate. The reason hospitals end up looking like a bunch of stacking blocks in a, some type of Lego set is because you do have that core issue of, life safety support issues, the oxygens and all the gases that have to be around the hospital. And the closer you can keep those blocks together, the closer that it is better for patient care. And to Orman's point, someone has a surgery, goes up to the room, has some kind of unwanted outcome, they immediately want them back down into the ER, back into surgery. And you don't want to have to go get them from across the street and come across a takeaway. So that's one issue. And we want to do everything we could to make them look aesthetically pleasing to everything that's around us. But what's happened in this case is everything's grown around it. And now we're landlocked. And we've got a problem with parking, and we all know that. And our first iteration of this had trying to solve some of the parking, but then it got really high, and so that's the reason you see the place that we have there now. The medical overlay district, we have a medical overlay district in Daphne. I think we have one in Mobile and in Bay Minette. And the medical overlay district here, to Lee's point, and I can understand it, is we were worried about doctors leaving and moving to Daphne, going to other places. So it's oriented to the south. And so that space is available for those type facilities. It really doesn't address the hospital's needs. The medical overlay district is good for trying to retain physician offices and independence, but it's not good for the hospital because we are landlocked and we don't have right of eminent domain. We are not a governmental entity, although the healthcare authority that actually owns the hospital is. We lease from the healthcare authority. We operate it under a 99-year lease, but we can't go to Northrop and say we want to buy every house here. We've tried, and we bought a handful of them, and then, but we don't have the right to expand and get into that medical overlay district. So I agree with us. Let's solve this problem and bite off, one bite of the elephant at a time. But in a global overview of where this community is going and the number of subdivisions and residents moving in. When we first did this merger between Thomas and Infirmary, the census was running around 85 patients a day there. And so I'm calling Orman over the weekend because I get calls over the weekend. Somebody's been waiting on a room for 2 days. We got 20-something people that are boarding in the hallway and everywhere else. So we solved this today. We're still, 18 months away from putting a patient in a new bed. So those are the issues. I'd like to look at the overlay district again down the road to see how we could help address that, because we can't grow to the south with private property owners. So happy to answer any questions.
So, if I may, Councilman, so, since we're talking about it, let's talk about it. We're talking about parking. One of the reasons in our meeting that we rearranged that parking, the level, was the height. So, logically thinking, if we're talking about doing regulation transformation as far as the medical overlay, and we're talking about killing two birds with one stone, we might want to think about putting that trifecta back under, keeping that height where it was with the parking. That's just a thought. That's my opinion, since that kind of helps with the parking process for right now.
We're trying to just respond to the comments that we've heard. We have a parking problem today.
I know.
My favorite description of parking problem was Lee Turner saying, you don't have a parking, you have a parking problem, you don't have anybody in the parking lot.
Yeah.
So we got a full all the time, and we don't know where to put them. And so we add these beds, they're going to bring family members with them, and they're going to bring other people to come. And so maybe there's a different location for a different parking solution other than right there. But we're not picking up any space by putting that one level. We're picking up, Dennis Summerford is with us as well. We're picking up 5 to 6 spaces net, because there's already parking there now. Then we redesigned that. We pick up 5 or 6 spaces and we go up, but we've added 30 beds and we're shelling in for another 50. So by the time we build that out, you're going to need another 150 spaces already.
Yeah.
I'm sorry, Mayor, you were.
I've had, actually, somebody text me and ask me the question. They wanted to know why we needed to call this joint meeting. Can you talk about your timeline for getting approvals and possibly submitting for another CON? I
Right.
think Orman touched on that earlier when he talked about the capacity.
Yeah.
But
So we weren't opposed on the CON. There's a regulation and Orman currently sits on the board up there. But there were some provisions put in that if a community is growing like this one and you attain a certain occupancy level for 60 or 90 days, then you really check all the boxes for an automatic approval to either go 10% or greater of 10% or 30 beds. So we went to the 30 beds. It was unopposed by any other providers because there's an obvious need. But that CON is typically good for 1 year. And I think we've been running up on that in March or so. And so what we're trying to do is show that we are making progress. If you make progress and you can show and we've done a lot of work with drawings and everything else, then you can ask for an extension of that. But what we don't want it to do is expire. Because if we have to expire, then we have to requalify, then we have to start over. Now, there are some projects that are currently going on inside the hospital that I think Dennis Norman will tell me about today, that we may be able to use those as significant progress to qualify for an extension. But the extension is not going to be, we may get another year out of it, but it's still, by the time we have to go through all this process and then the engineering and the design and supply chain is a huge issue still for us. We still can't get certain things, whether it's generators or saying we need to be ordering way out so that we're going to get delivery in September or October for some key issues. So, but I think I think this meeting shows progress. I think some of the stuff we've done inside of the hospital is going to help us with that. But the more progress we can show toward getting to a solution, all of those will be part of our application to extend the CON.
And this also gives us a general consensus that every board that you have to go through will more than likely, hopefully, they're giving you some good comments, and you can have your plan ready. So when you go before planning and zoning, or you go before Board of Adjustments, or you come before the city council, that hopefully you would get approval.
Right, and I hope that's what we're accomplishing. Yeah.
Mr. Chairman, Mr. Nix,
Yes, sir.
thank you for being here today.
Yep.
So that to council president's comment about just taking this a bite at a time, I want to know, as probably going to sit down with Hunter and the mayor, maybe council president, and I'm kind of thinking we might tweak this ordinance. I think that's maybe what I'm hearing, right? And so in the process of doing that, we can look at the medical overlay district and maybe see if it's time to tweak other things. I don't want to get bogged down in that so that it slows us down. But is there anything we need to know? Are we taking a big enough bite of the apple now? Is there, I mean, if we write this, if we amend this ordinance and we need something else in a year or two, how long is this going to sustain you? Is this a 5-year plan, a 10-year plan? Do we need to be looking beyond this right now?
Right.
Are we taking,
I
are
would
we
say-
doing enough?
So we have 30 beds. We've already kind of accommodated 5 inside the hospital. That's the reason this first floor is 25. And so we got 2 floors above that to shell in, which is 50. Quite frankly, by the time we finish this and we put all the people that are in the hallway and everywhere else in the beds, we're going to requalify for another 30 beds, which is the reason we want to just build at one time, so then we can start the next process. So it's not unreasonable to think that within 3 years or 4 years, we'll qualify to build out the entire additional 50 floors above this. So now we'll be looking at, a 250-bed hospital or 260-bed hospital. And so that's already built in there, but it brings all those other issues. If everyone is so willing, and I hate to compare, but this is the only experience that we've been through, the Daphne overlay district was geared toward the hospital. It was geared to what that campus, and it's about 60 acres, I think, there. So we kind of put our input in, but when the overlay district in Fairhope went in, it was really more about let's accommodate, the physicians so that we kind of keep everybody in. So if we could like look and compare about what things would make it easier for us to grow and not have to come back to another council in 2 years, that would be beneficial.
Yeah, so that's exactly what I was thinking. I think there will be other meetings after this, and hopefully you guys can be involved as we kind of chomp through making decisions on creating a true medical overlay district. I think we would have to get insight and information from you guys so that we can come to our best opportunity moving forward.
Yeah, and you made a great statement about residents, because we're very proud of that program. We're training over 40 physicians right now. We want to continue to grow that program.
Yeah.
Ultimately, we would like to move the residents off the campus. We need another campus for that. We need another campus for those medical students to live. We need another place for them to operate a clinic. Right now, they're doing it out of the professional office building that we're there. So we're pulling all that traffic in there for people to come see those residents in training. If we can get them, and we're working on that, to another location somewhere, decompress the traffic around the hospital, it would be beneficial to us.
Yes.
So we're not interested in going up with resident towers and things like that. We got very limited space there, and it needs to be focused on hospital.
Very good. Yes, sir.
Okay, thank you.
Thank you, Ms. Nix. Okay, guys. Does anybody else have anything else to add as far as this meeting is concerned, concerning information towards the expansion of Thomas Hospital? All right. Hearing none, we'll call this meeting to order. All right. Thank y'all.
Thank y'all.
Yeah.
Well done. Well done.